When we speak of again, nature and ideas for
He can't hear. He can't hear.
Now, talking about experiences of Africa, the current situation
I was able to hear
health in Africa.
So we have quite a number of items that are going to be discussed by the meeting in the next few days. So, and we expect quite a number of items actually to come up. And right now, the meeting has started actually looking at advancing resilient and self-reliant health systems for attainment of universal health coverage in the sub-Saharan Africa. And this session is going to be moderated by Honorable Dr. Joseph Munsanje, who is also chairperson of the Committee on Health right here at the National Assembly. So we cross over to the floor for the live proceedings of this particular meeting. So for now, it's good morning.
The satisfaction levels are very low, and people are saying our government needs to do something about health in our country. And then there was a second question, or another question. They were asked, in the last 1 year, in your household, has any sick person missed health services? And 66% said they have missed services when they needed services. They were sick, they needed to be treated, they could not access services. So 2/3 of our population in the last 1 year say they have missed a health service. And when you look at the distribution, most of these are people from rural communities, over 70%. Most of them are really agricultural workers. So these are our peasant mothers, sisters, brothers in the villages. And most of them are people who are not employed. Now, in another study, looking at why are people dissatisfied with health services? Why are they saying our governments need to do something other than employment? Why is this the second most pressing problem? There is a scoping study again done on this, and the reasons, one is long waiting times. 80% say this is a big problem, lack of medicines or other supplies, facilities in poor condition, and absent doctors or other medical staff. These are really the big challenges our people are facing. And about 20% say they had to pay a bribe in order to obtain the care they needed in health facilities. On government performance, 70% say their government is doing a poor job on improving basic health services. So again, I want to say Africans are very dissatisfied with the recent issues around their health and what their governments are doing to help them access health services. We know that the current situation, which seems to be worse than what it has been before, what the people are saying in the recent years, the perceptions seem to be worsening, is because external health aid to Africa has dropped by 70% since 2021 to date. So the monies that were coming, the external support has drastically reduced. Meanwhile, disease outbreaks have gone up by 40%, and our health systems remain weak, so they are overwhelmed. And one thing that is worrying in this situation, and you know the story of COVID and everything, we are still very dependent on the West, even for health commodities. And we rely a lot still on external financing, despite what appears to be a very telling trend on the external support to the health systems in Africa. The other thing that is very important to note is that the dissatisfaction or the inequity in access to health is growing. And I don't know whether I'm able to show this. But that red graph, okay, not able to show, but what looks, I think that is orange, no, reddish, or whatever color. If you look at why inequity is so common, the first one there is social capital. Especially people in marriage and who are connected. If you are not, then you seem to have more problems. The second one is your socioeconomic status. That is the third thing there. That red line shows that if you are not socioeconomically well off, your chances of getting health services is very low. The third one, which is big, is education. If you're not educated well, your chances of accessing healthcare very low. And the next one, third from down, which has that reddish color, is occupation or ability or employment, ability to, or if you are employed, you're better off than those who are not employed. And the last one is your place of residence. If you are living in rural places, then your chances are worse if you want to access health services. Now, the message here is that the social determinants of health, which is social capital, your socioeconomic status, education, whether you're employed or not, whether you live in the rural place or not, are really drivers which are outside the Ministry of Health. And so if we are going to change health, then we have to think beyond the health system, and we have to think beyond the Ministry of Health and see how do we change these social determinants of health. So those are I said I was going to talk about three things. That is the current status and drivers of the health in Africa. I want then to just talk about three priorities, which I think if we pay attention to, we might be able to change some of the current situation. I know Africa has the first priority that I want to talk about is strategy and health diplomacy in Africa. I know Africa has responded to this current challenge quite a bit by talking about health security and health sovereignty. What we are currently just calling AHSS. That is something we need to have. And AHSS recognizes that achieving universal health coverage, pandemic preparedness, and sustainable development cannot be realized without health sovereignty. And for those who may not have come across this, when we're talking about health sovereignty, it is the ability of African nations to finance, produce, and govern their own health systems and countermeasures. So this is being seen as important, taking charge of our own health, taking charge of our future when it comes to health. And this is something the AU is really strong on. And how are we institutionalizing this? By adoption of a presidential declaration to produce at least 60% of health products locally by 2040. And this declaration was done at the 39th ordinary session of the AU. And a call to action is there, which includes pooled procurement, financing mechanisms, and skills transfer across member states. And Africa CDC has been, made central to the strategy of championing African pooled procurement mechanisms and demand aggregation and long-term offtake agreements, and so on, and pooling funding and buying from African manufacturers. The second thing in institutionalizing sovereignty has been thinking differently about health, which I think one of the earlier panelists talked about, positioning health as a cornerstone of economic and security sovereignty. And you may know this gentleman, Clever Gatete, saying that health sovereignty is ultimately economic sovereignty. And we always say that you cannot be economically productive if you are sick. So health is no longer a social service. It is being positioned strategically as an economic and security issue. And this is part of institutionalizing health sovereignty. And you can read a lot more about health security and sovereignty agenda that AU has come up with. The only thing I want to say here, all is good. This thinking is great, but no nation can prepare for pandemics, climate shocks, displaced populations, or supply chain vulnerabilities alone. And Africa must design a global health strategy where sovereignty sets the agenda and multilateralism enables it. We always have, yes. So in Africa, we talk of witchcraft. When you seem to be doing well, then someone bewitches you. Yeah, we hope it comes back. The whole issue of health sovereignty, positioning health as a security issue is great thinking. But in addition to that, we must also still have multilateralism. You remember COVID came from China. The problems of pandemics, climate change, and so on are multilateral, they are global. And so as we position our health sovereignty, health security, we must not drop multilateralism. The emerging inward-looking policies of the West, which have become very strong of late, should not drive Africa to be inward-looking at the expense of global health, because that will only make things worse. Okay, now I can't move the slides. Something is okay. So Africa can be the voice of reason in a fast degenerating global health architecture. We need our Africa First strategy that we all believe in and that we can use to advocate globally. You know something which is worrying? The American First strategy, 14 countries have signed it. Yesterday, I saw Zimbabwe has officially denounced it and they are not going to sign it. Kenya signed it, then the parliament, or the courts overturned it, and they talked of sovereignty and interference with sovereignty through that arrangement. What is the position of Africa Union? What is the position of Africans on this issue? Why should we have that divided position? I think we will be very strong as Africa if we went to the US and said, we appreciate what we are doing, this is our stand, can we negotiate and have a win-win situation, rather than some signing, some rejecting, some courts overturning. That divide and rule strategy has not helped Africa before, and is not going to help Africa in future. So as we talk about our health strategy, health diplomacy, we must now come together as Africa Union, as NEAPACOH, and have a stand that can guide our governments when we are signing these multilateral agreements. But for us to succeed in our health sovereignty, we must have multilateralism. The second thing, so this is what health sovereignty will look like. Because of time, I think we've talked about it. The second thing I want to also talk about, the second priority for me, is Africa's health workforce. Again, some of you know this gentleman, Jean Kaseya. He says the evidence is unequivocal. Investing in Africa's health workforce is not a cost, but a strategic investment in health sovereignty and economic resilience. So according to the African CDC, investing in Africa's health workforce, for every $1 you invest, it yields 19 US dollars. And inaction in this area is estimated that will cost us 1.4 trillion by 2030. But there is one cadre which is specific and unique to Africa, the community health workers, which is unique to African health workforce. If we have strong community health worker programs, we will transform health in Africa. Those 66% of Africans who cannot access healthcare. We've seen they are from rural communities, they are agrarian, they are uneducated people, they are households which have no income. Who is the first person who reaches them? It is the community health worker. Now, right now, we need 2 million community health workers in Africa, but we only have about 900,000. Those 900,000 are mostly in Uganda, Nigeria, Kenya, South Africa, and a bit of, I think that's Madagascar. The rest of our countries still don't have strong community health programs. These are the people who will help you detect disease in time, will help households to improve their health so that they don't crowd in health facilities. This is a transformative action if we take it, if we can invest in community health workers. But we are not doing well. We are underfunded in this area to the tune of 5.4 billion annually. And the funding systems for community health and community health workers are disease-focused and fragmented. Most of these community health workers are women, 70%. They work as volunteers, which I think is an injustice. And they're affected by economic operational challenges, lack of supplies, equipment, appropriate training, and so on. I think the message is, if we have to transform our health in Africa, it is very unique to Africa because of our infrastructure and where our populations live. We must fund community health programs, and the pillar of that is a functional community health worker program. So political prioritization of this is important. Ensuring they are adequately trained, supervised, and compensated, very important. Organizing this program so that it is coordinated, so that we don't have fragmented programs, that there is one plan for it, one budget, one M&E, so that not every donor is funding in a haphazard way is important for our countries. My final point, which I think we need to pay attention to, is what I call advancing new opportunities. And there are two new opportunities for Africa, which I want to talk about: self-care and what is called digital health, which you all know. Self-care, according to WHO, is the ability of individuals, families, and communities to promote health, prevent disease, maintain health, and cope with illness and disability with or without support of a healthcare provider. Those 66% of Africans who missed care that we talked about, what happened to them? They basically had self-care. And self-care is healthcare. It includes self-awareness. Okay. Thank you. It includes self-awareness. Owning your own health information to promote your health. It includes self-diagnosis, knowing that I may be sick, I need cancer screening for cervical cancer, so that it's diagnosed early enough. It includes self-diagnosis at home. Things are now digitized. We should have some of these things available to communities to use. It includes self-management, healthy lifestyles, home remedies, self-referral in good time. It includes a policy environment that is enhancing. And that policy environment basically is having self-care as part and parcel of healthcare, which currently is not available in many countries. There are countries which are leading in this currently, Kenya, Uganda, Nigeria, which have formalized self-care and are doing very well. This is just an overview of what self-care can do. Greg Perry, the Director General Global Self-Care Federation, summarizes it this way. It is a proven catalyst for stronger, more sustainable health systems. Research shows that self-care currently saves 120 billion globally annually, and is estimated 175 billion annually by 2030. It frees up billions of productive days and improves quality of life worldwide. These benefits create a win-win scenario. Individuals gain autonomy and fast access to care, while health systems reduce costs and free up resources. So self-care needs to be institutionalized. I put this slide here, I may not talk much about it, to show how Kenya has gone through formalizing self-care so that it's part of healthcare. It is time for countries to prioritize and institutionalize self-care as a strategy to increase access, resilience, and self-reliance, and to save costs and make access to health possible to everyone. Finally, the potential of digital health. Digital tools and solutions can reduce healthcare costs by 19%, reduce medication errors by 50%, increase operational efficiency by 30%. And currently it is estimated that AI applications alone could save 1 million African lives by 2030 if we implemented those solutions. So there are many solutions. Again, I don't have time to talk about them, but there are very many solutions ranging from data analytics to, interventions in healthcare, drones, genomic medicine, biospecimens, and so on. It's a big thing. And I know countries are working towards this. At AU level, there is great movement on this. You may be aware of the Africa Health Tech Marketplace. Africa CDC is now listing tested solutions which countries can adopt. And if you go to their site, you can see some of those very well tested solutions that countries can pick and implement. But African governments need to prioritize and finance digital health as a strategy to accelerating achievement of UHC. And we can achieve UHC very fast through some of these initiatives. So in conclusion, advancing resilient and self-reliant health systems for attainment of UHC in sub-Saharan Africa. Are African countries on the right trajectory? Let me say there is a lot being done. Health access is still, however, a challenge in Africa. There is high dissatisfaction with services, and people are saying our governments need to do something. Determinants of access are both within and outside the Ministry of Health. There is need for action by actors within the ministry, but partnerships to improve those things that are outside the Ministry of Health remain important. Africa's response is health security and sovereignty, but this needs cross-fertilization with multilateralism for effective global health. Community health worker programs unique to Africa are the backbone of our health systems, and we need to improve and finance them. Self-care is a new opportunity. Let's finance it, let's institutionalize it, and finally, digital health has great potential and can help us improve very fast. Thank you very much.
Thank you so much, Professor Joachim Osu. Another big hand for Professor, please. And I will invite you to come and sit with us here. I think you add to the panel discussion as well as we invite the panelists. So we have seen a very important presentation from Professor Osu from Amref University, where he has given us very important information, and I think key is the 3 priorities he puts for the Africa health systems. And so we'll wait to hear from the other panelists. We were also supposed to have Mr. Linton Muchu, senior advisor from the Audi NEPAD. Unfortunately, he's not with us. So we have, however, in the house, Dr. Nuruddin El Hassan, lead environment and climate change from AFIDEL. Please, a big hand for Dr. Nuruddin El Hassan as he comes to take the floor on this panel discussion here. Please, you can go ahead to offer your presentation, and then you move over here to take the panel. So we'll give you about 20 minutes in the interest of time because we're already behind time. Our session should have been at the discussion point right now. So we'll give you 20 minutes. Thank you.
Thank you, Chair. Good afternoon to you, honorable members. Just to go back to the introduction in the morning, my name is Nuruddin Al-Hassan. I'm a senior research and policy analyst at the African Institute for Development Policy, AFIDEP, and I'm based in our head office in Lilongwe, Malawi. In the morning when the introductions were made, I didn't know whether to say I belong to the Ghana delegation or the Malawi delegation, because I'm a Ghanaian, but lives and works in Malawi, and have lived there for the last 7 years, so I consider Malawi as one of my countries. Are the slides being uploaded? Okay, thank you. So this morning, when we were singing the national anthem, the AU anthem, I think I had a reflection of the last stanza, if I may call it, which says, "Let us make Africa the tree of life." I think it implicitly suggests that the environment, which I consider the tree to be symbolic of, is really central to health. So my presentation this afternoon is going to look at how we can advance a self-reliant and resilient health system within the UHC framework in sub-Saharan Africa, specifically zooming in on the role of climate change, and then speaking specifically to SRHR, and then the role of MPs. And my presentation, I would briefly look at Africa's UHC commitment and strategy, how climate change health has been integrated into climate change policies in the region, looking at the impacts, best practices, and then ending with what members of parliament can do. Since the opening ceremony and Professor Oso's presentation, I think it's clear that his concluding remarks was that, is Africa in the right direction? I think his answer is yes, but very slow. If you look at the service coverage index, which is a measure of the extent to which we are reaching people with health services in Africa, you realize that since 2000, which is almost around the time when the Abuja Declaration was being made in 2001, we only had a coverage index of around 20%. 25 years later, it's at about 46%. So we are in the right direction, but very slow, which means that we are just increasing coverage by 1% on average every year for the last 25 years. Not good enough. Our UHC commitment, if you look at the AU, is really founded on several policies, including the Maputo Plan of Action and all that. But I'll highlight the Abuja Declaration, which talks about resource allocation, and then also talk about the AU Agenda 2063. I think it's very important. The Agenda 2063 is important because of the shift in how health is being viewed. So we are no longer looking at treating health as just dealing with specific diseases. I know some time back we would have been discussing a conference on malaria separately, cholera separately, dealing with HIV separately. It's really looking at addressing the system. Now, if you look at, again, at the regional level, what are really the pillars of our UHC strategy? It's built on 3 key pillars. One is institutional strengthening, regionally looking at Africa CDC, and at the country level, we are looking at strengthening the ministries, strengthening both the institutional and then the individual capacity. Then domestic resource mobilization. I think it's a point we need to re-emphasize because we are now in uncharted territories, because for a long time, our health budgets have been left to external funding. So right now, that pillar is also critical. And the third one has to do with integration. You can no longer treat health as a stand-alone because there are implications for other sectors. I'm going to talk about climate change now. I know we've mentioned in the morning that climate change is probably one of the biggest global events that is facing us now with serious implications. For some of us who come from rural communities, this is already a lived experience. What are the pathways through which climate change affects health generally? First, you have to look at mortality, the mortality levels. And if you look at the projections, mortality is projected to keep rising because of climate change. And the last estimate showing that about an additional 532,000 deaths are projected to occur due to rising temperatures and floods from 2024 to 2050. And I live in Malawi, so I just give an example home to look at Cyclone Freddy, which happened in 2023. I was in Malawi. And this had serious destruction on human life. So these are experiences we are going through. The second has to do with how climate change is, even apart from the direct effect on mortality, looking at how it's going to make disease conditions and the spread of diseases easier, specifically malaria and cholera. And if you look at the cases, the projected cases, significant increases in malaria and cholera outbreaks directly resulting from floods and other environmental conditions created by heat and then heat conditions. Apart from these direct effects, climate change has indirect pathways on health. One has to do with its effects on food insecurity and malnutrition. So stunting in children, wasting, these can trace their ways back to climate change, because if agricultural productivity is not good, you can see the effects on child malnutrition. Then on health infrastructure, already the coverage of health infrastructure is poor. So if climate change is affecting through floods, disasters, cyclones are affecting health infrastructure, it means that access is even going to be constrained. Return to the regional policies and frameworks that have been put in place. How have we tried to integrate health into climate change at the region? We've done basically 4 key things, or 3 things, generally. Last year, the Africa CDC released the first regional climate change and health strategy framework. And if you look at that framework, it's really the first attempt to recognize and to see how we can address the health impacts of climate change. After all, health is really the human face of climate change. So that regional framework is important. Most African countries have also revised or updated their nationally determined contributions to prioritize health, which is good. And a number of countries are also developing separate health national adaptation plans, which prioritizes health adaptation in those countries. I think Kenya, so far, is the first country to have a separate national strategy on climate change and health, which is significant because it addresses comprehensively the health sector and environment and climate change. Now, there are important policy gaps if you look at these policies. One of the things, despite these policies, what you see is that there are still huge gaps, with only 35% of countries across the region having policies that actually recognize the intersection of health and climate change. So about 65% of our countries still don't have policies or governance frameworks on this. Now, sexual and reproductive health. I think it's been mentioned, and I'll return to this, that this is probably one of the most important areas that we need to pay attention to. Despite its importance and how climate change affects it, it's not explicitly mentioned in any of these policies I have listed there. So if you go to the HNAPs, you go to the regional strategy mentions maternal newborn child health, but it doesn't pay attention comprehensively to SRHR. And then the HNAPs are not doing a good job either. And we already mentioned the capacity of the health system as a challenge, and then data. We need to be able to integrate data from the health sector, the climate change sector, the social sectors. After all, poverty and all the other inequalities have implications in exacerbating the interaction between climate change and health, and then funding. If you don't have the resources, you are not going to go far. So I return to the poor recognition of SRHR in our climate health policies. We believe strongly that this is a major oversight. Why is it a major oversight? Because climate change directly and indirectly affects SRHR outcomes. And all of us know that Africa cannot achieve our Agenda 2063 if we don't address the issues of SRHR and population dynamics. The issue of harnessing the demographic dividend, the issue of empowering women and girls, creating access to service delivery, and then addressing unmet need for family planning. These are important issues. Yet, if you look at the policies, and within the current context, for a long time, our SRHR sector has been left to external donors to support development partners. So if there's already pooling of funding with the withdrawal of USAID and other donors, that SRHR sector is struggling. And it's not also being prioritized. So we are really dealing with double jeopardy. Yet, climate change is expected to disrupt access to health services, SRHR services. If you look at the examples, in terms of climate change being linked to disruption in access to family planning and HIV services, and I showed the examples of Zambia and South Africa. Droughts have also been linked to early sexual debut, early child marriage. So if you are addressing issues of child marriage and you don't pay attention to climate change, there will be reversals. Because when children and young girls don't have access to food because agriculture has not done well, parents are likely to, as a coping strategy, to give out their girls for marriage. Young girls are likely to engage in transactional sex as a way of survival. So all these have implications on fertility, on SRHR outcomes like child mortality, and then even HIV infection. And we also see intimate partner violence. When families are struggling to cope with the impacts of climate change, frustrations are meted out. Globally, it is estimated that a 1% increase in global temperature is associated with 4.5% increase in intimate partner violence. In some countries, it's even higher than the global average. The good thing is there are scoping exercises that show that there's an opportunity to actually address climate impacts on health through SRHR interventions. So there are interventions on SRHR actually have direct impact on climate intervention. If you were to provide access to contraceptive services, if you were to reduce teen pregnancies, address child marriage, it will go a long way to impact consumption, impacts on flooding, and all that. Also, if you address climate change, again, you are also addressing SRHR. So it's important to note that climate actions can improve health outcomes and boost SRHR in particular, such as child health and then GBV. Now, if you look at what are some of the best practices that have been shown so far from policy, data, infrastructure, and equity issues, I document a few. This is not exhaustive. Some of you will not find your countries here, but I show some of the examples that I think that we can learn from. One has to do with the issue of policy and governance. I mentioned earlier that only 35% of countries have policies that have climate change and health in them. Now, Uganda and Ethiopia are countries that have developed specific health national adaptation plans. Kenya has a strategy on climate change and health. And I invite you to look at it and see what you can borrow from it for your country. Energy transition. We already have issues providing access to energy in our countries. Some countries have decided to provide health facilities with solar grids to ensure constant supply of power to health facilities, therefore reducing the risk of mortalities resulting from disruption in power supply, whilst at the same time reducing emission. And we have examples of that in Namibia and Chad. We also have data systems integration. I mentioned earlier that you cannot model the impact of climate change on health if you don't have integrated data. Some countries have already started their DHIS2 integrating climate and health in their models, Ethiopia and Malawi being examples. Our host country, Zambia, actually talks about equity. We mentioned that you cannot achieve a lot if you don't address issues of inequalities, both accessing SRHR and generally health outcomes. So Zambia has comprehensive climate change gender action plan that integrates equality into climate, health, agriculture, and disaster strategies. I'll end by returning to MPs. I know in the morning we talked about your role as members of parliament and how it's important. I think a lot of the discussion looked at your oversight role on budgets and then also allocation. But I summarize the functions of members of parliament under 4 teams. The first has to do with legislative and policy oversight. We need members of parliament to be able to have significant oversight so that our health systems can be prepared for the adverse impacts of climate change. And I mentioned some of the specific things that MPs can do. For instance, ensuring that there's explicit integration of health into climate policies. It shouldn't just be implied in the policies. It's mentioned with specific targets that members of parliament can track. Also, members of parliament are important in terms of even looking at these innovations, providing to say that, okay, for us to approve a budget or a health project, infrastructure, we need to have some minimum climate sensitive actions. Like, okay, can you provide certain infrastructure that meets and help this, that facility to be resilient so that you don't build a hospital and the next flood, the hospital has collapsed and all the money is gone. I think that is also a good point that members of parliament can think about. Then on budgetary controls and resource allocation, I think that we already talk about generally health financing, but even if you go health financing within climate change, it's less than 1%. So we are not even dealing with the Abuja 15%. So members of parliament can advocate for increasing the health sector's share on climate finance. And members of parliament, again, should be prioritizing SRHR, because if you look at the impacts that SRHR has, both directly and indirectly, if we don't address and include that as a major pillar of our resource allocation, we are likely not to get a lot of progress. I will go to representation and community advocacy. Our members of parliament are representing communities. Some of those communities are actually the faces of climate change. So if the representatives of these communities should be involved in vulnerability assessment, right? Helping to identify specific communities in their constituencies that are vulnerable to the impacts of climate change. Also, creating awareness. Members of parliament have a voice. So if members of parliament are going to step up and create awareness to show the community that, look, there is an implication and a link between what the health conditions that are emerging in their constituencies and the environmental variability or climate change issues in their community, it's important. And then even serving as feedback loops. People implement strategies at the national level and they report outcomes. Yet in your community, it's not having an impact. The MP can serve as a feedback loop to say in parliament, look, this strategy is not working in my community. Here are the things that work, here are the issues that don't work, so that national implementers can take on board those feedback into revising the policies. And then finally, parliamentary diplomacy. We are here at NEAPACOH. I think this is an important forum for us if we want to engage our peers. Our countries have borders, but the climate has no borders. Even though I flew in from Malawi 1 hour, when I got here, there was no difference in terms of the weather. It's the same weather. So I know I have moved across the boundary, but the weather stays the same. So I think there should be cross-border collaboration, and it's good we have NEAPACOH. It could be a platform for members to discuss issues around the region, regional threats, and then elevating SRHR in our discourses and interventions as members of parliament, and then even looking at how do we address and amplify African voices in resource allocation. I mentioned the budget we have for health financing in climate change. We need members of parliament to advocate. And we are happy that all of you here, by your presence here, are already showing commitment to this. Hopefully, we can push this agenda forward. I'll close by restating this statement I made at Addis at the Africa Climate Summit last year. Africa must integrate health into climate frameworks, stronger governance, and financing. We need to scale up intervention with proven health benefits and learning from countries that are already leading the way. And I showed some of those countries. We can ensure health is never sidelined in climate action, specifically SRHR. Thank you.
Thank you so much, Dr. El Hassan, for this very powerful presentation. Please, I'll invite you to the stage here. Another big hand for Dr. Hassan. Honorable members, I now have the pleasure to invite Vivian Siganga, Country Manager, Amref Health Africa in Zambia. Vivian, please, you may speak and address the House on perspectives of civil society on preparedness of Africa health systems for emergency response, equity, resilience, and sustainability. Please, you can take that in the context of attaining universal health coverage. Over to you, Vivian. Thank you. The main one, yes.
Thank you. Thank you, Honorable Member, or Able Chair, and members of Parliament. Good afternoon. I want to start by, I don't know if I'll call it boasting, but we as civil society have a very good relationship with the Parliamentary Committee on Health. And over time, their doors are open for us to engage on various issues that affect health, and we see these issues being adequately addressed. So I'd like to thank the Parliamentary Committee on Health in Zambia. As introduced, I'm Vivian Sakanga, the Country Manager for Amref in Zambia. And also as Amref, we belong to a network of non-government organizations called Partnership for Maternal, Newborn and Child Health, where we advocate for issues around maternal, newborn and child health. So I've decided to speak because sometimes speaking last, you have a disadvantage. You find that some of the issues that you wanted to speak to have been already addressed. And so I thought I could have a reflection based on the presentation that has been made by Professor Osu. And I'm going to start from the question we're being asked as civil society is, are we on the right trajectory with regards to Africa health systems being prepared to respond to emergencies while advancing equity, resilience, and sustainability in pursuit of universal health coverage? So from the lens of civil society organizations, we're looking at aspects of preparedness, not just being infrastructure and surveillance, but we also want to look at it from the perspective of the people that are being served, the people themselves, the protection of human rights, the aspect of accountability, and of course, equity that was spoken to by the former speaker. And we think this conversation is very relevant at this time because we are seeing increased frequency of health emergencies. We've just come from the COVID pandemic. Ebola has been on our doors for many years now, and now we know that quite a number of countries, including Zambia, we do have cholera outbreaks from time to time. And then we are seeing quite a lot of climate-related disasters, Mozambique, Malawi, and also in the drought in the Horn of Africa. And then we still have conflict that is also affecting provision of services. And lastly, as we talk about equity, we are looking at persistent inequities in provision of health services. So when we look at emergency preparedness, where do we stand? Again, Professor Osu talked about health sovereignty. And from that angle, I'd like to say really from the regional coordination, we are seeing strengthened Africa CDC. No, I'm not presenting. Yeah. So from the Africa CDC coordination, we are seeing demonstrated leadership during the COVID response, as well as the aspects of procurement. How do we become our own manufacturers of commodities, including medication? However, we are still seeing challenges at district level in many countries, where aspects of stockouts are an issue, and also delayed response capacity. So in as much as we are seeing the sovereignty at the continental level, we need to start seeing it trickle down to the countries and also to the communities that we serve. And we feel also, in as much as there's this sovereignty, emergencies in a way create a bigger gap in terms of who is being left behind. We see that rural communities are still not adequately covered, informal settlements as well, and those who are hit the most, the women and adolescents. We see that the services, especially as we were talking about the SRH services, but also would like to add on the maternal, newborn, and child health, how those services are not still being adequately covered, and we're seeing a higher rate of maternal mortality in most of the countries. So we have some examples, of course, in terms of maternal mortality, how countries are being still have some progress, but it's not adequate. And so without this equity being addressed, where we are seeing people in the rural areas, our grandmothers, our relatives receiving the services, will not be able to achieve UHC. And earlier on, Professor Osu talked about the health workforce. Yes, we do believe that we need the health workforce. We have not yet achieved the health workforce that is needed. We know that it's the backbone of provision of services. So there's need for that investment to continue being done. We know that Africa carries about 24% of the global disease burden, but we only have 3% of the global health workforce. So that shows that we still have uneven distribution of healthcare workers in Zambia, in Zambia and Africa at large. Then I go to the aspect of community health workers. Professor Osu has rightly put it that they are really the link between the health service provision as well as the communities. And we see that in countries where we saw a good response in terms of continuity of service provision during emergencies, they have strong community health systems. We can give an example of Rwanda, for example, where they have a strong community health system, and they were able to maintain essential health services during the COVID-19 period. We also know that Ethiopia has a health extension program that has strengthened PHC resilience, and Senegal, of course, in the West, that was able to conduct rapid testing and local innovations during the COVID-19. So primary health care needs to be invested in before the crisis. We are seeing that countries that did very well or were able to continue providing services during that period, they had invested in primary health care before even the crisis happened. So we need to build resilience before the crisis happens. And our advocacy as civil society organization is to ensure that there's PHC investment as the backbone of resilience. We've talked a lot about domestic resource mobilization, and this continues to be also what we feel is lagging behind. In the morning, Mr. Zulu spoke to the Abuja Declaration, how maybe we should not continue talking about the 15%, but encourage countries to continue investing. 15%, only few countries have been able to achieve that. We have examples of Botswana, Cape Verde, South Africa, and Seychelles, who are currently funding more than 50% of their budgets. So those are lessons that we need to learn from. How do we increase domestic resource mobilization in country? We have had heavy reliance, the former speakers talked about it, the heavy reliance on donor funding and how that has disrupted service provision. So we need to become self-reliant. And as Member of Parliament, you play a critical role in ensuring that that pool of resources is created through policy. So the question is, are Africa health system prepared for UHC in crisis context? We've seen some strengths around, I talked about the regional solidarity, the Africa CDC that is playing a critical role in ensuring that there's coordinated mechanisms. The PHC innovations, Dr. Osu talked about digital health, how it is supporting the provision of services. The community health models, I know currently in Zambia, we are implementing the polyvalent community health worker who is going to be this generalized healthcare worker who will be able to visit the communities and not just attend to one disease area, but be able to provide a comprehensive and integrated service package. However, the weaknesses are still there. I talked about the financing fragility, inequitable access, supply chain vulnerabilities in terms of stockouts, and also governance gaps. So if we want to measure trajectory by policy reform, regional coordination, and increased insurance coverage, then yes, there's measurable progress. However, if we want to measure based on financial protection, equity in rural areas, and sustainable domestic financing, then the progress is insufficient and uneven. We are seeing a positive trajectory, however, it is fragile, and we need to ensure that we create a stable base for this to be sustained. So moving forward, as civil society organizations, we have recommendations on what the members of parliament can take up on. We've spoken about how the women, children, and adolescents are the most hit, even in the aspects of climate change. The former speaker spoke to it. So we need to continue prioritizing service provision and ensure that it's sustainable and it remains resilient even in the times of crisis. Provision of sexual reproductive health, prioritizing that within the national budget, or how do we take advantage of the national social health insurance that exists in different countries. We've talked about domestic resource mobilization. I will not overemphasize it. Expand and retain the healthcare workforce with an emphasis on community health, and also continue investing in local manufacturing and supply chain resilience, and also strengthen the accountability mechanism. And this is where the civil society come in, to continue engaging with the members of parliament to ensure that we strengthen these systems and are able to be accountable on of the services that are being provided. I cannot overemphasize the role that primary health care is playing as the backbone of universal health coverage. And for this, we need continued political commitment that will be able to determine success. So in conclusion, we have seen demonstrated innovation, reform, and regional solidarity within Africa, which is very commendable. And there are strong examples where we know good works have happened, and also where countries are making strides in ensuring that service provision is provided equitably. So strong examples that we have are that of Rwanda, Ghana, Ethiopia, South Africa, that showed that this is possible. But we know that the progress remains uneven and vulnerabilities persist. So the good news is that as civil society, we feel that we are on the right trajectory, but acceleration and sustained political will and domestic investments are urgently needed to ensure resilience and true self-reliance is possible in achieving universal health coverage. Thank you.
Thank you so much, Vivian. A big hand again, please, for Vivian. Please, you can come here on the stage. We're now going to have an open discussion and question and answer to these panelists. We have about 20 minutes before our lunchtime, so we can use these 20 minutes to clarify issues from their presentations and the like. So any members with questions who may wish to raise, do we have another loving mic? Or should I grab, maybe camera person, can you help me with that mic there? Yeah, the other one, there was another one there. Down, yes. And it can be taken to our lady from Malawi and the gentleman. Yeah. So we can pick the two questions which have come up. We'll pick up to 3 questions in the first round. Please introduce yourself so that we continue knowing each other a little bit more.
Thank you very much, Chair. My name is Anthony Masamba, MP from Malawi and Chairperson of Parliamentary Committee on Health. I think my question is general. Thank you very much, all the presenters for the beautiful presentations. Issues around UHC. We are remaining with 5 years from now to hit 2030. But it appears countries are far or seem to be far away from achieving the UHC. And donors are pulling away, we know that. Issues of domestic resource mobilizations are what we are discussing here. Commitments are being made by several countries. Are we really sure that as a region we are ready to achieve universal health coverage? I'm asking this question because issues around primary health care, which is the beginning of access of quality health care services, it seems to be compromised. There are no major investments going towards primary health care. And we have congestion in tertiary, including the referral health facilities because of that. Are we going to achieve UHC? Thank you very much.
Thank you. There was another hand behind, the red dress behind there. Just, yes.
Okay, thank you so much. My name is Diana Tibesikwa. I come from Uganda and I work with the AIDS Healthcare Foundation as a regional policy and advocacy manager for Eastern West Africa. My question goes to, I think, the second speaker who presented about sexual reproductive health and climate change. And my question is, when you say sexual reproductive health to the members of parliament, what do you mean? Because I think we have seen some bit of progress in terms of what our governments are doing in facilitating sexual reproductive health initiatives. So do you want them to focus on commodities? Do you want them to focus on behavior change? Which areas do you want their effort, to focus on? Then the last speaker, the lady who spoke about some of the health financing approaches, spoke to local manufacturing. And in this room, we may not appreciate what the role of our members of parliament would be in advancing local manufacturing. Like, what do you want them to do? I think it will be good for us to come out and exactly talk about their contribution and the role to some of those processes. Thank you so much.
Thank you so much, Diana. We have a hand at the far back before we come to the fungu here in front, at the far back.
Thank you very much, and good morning to this august house. My name is Dr. Sakulanda Charles. I work for the National Health Insurance Authority here in Lusaka. So my question goes to Professor Osu. I think in your presentation, you did indicate that the inequities in access to health mainly lies outside the Ministry of Health. And you went on further to say health is a cornerstone of economic development of any nation. So I just wanted to get your insight. How do we ensure that as committees on health, honorable members of parliament who sit on committee for health, you will be able to draw in your other members of parliament in other committees to ensure that this access to health is addressed holistically, and it's just not the work of those who are sitting on the committee for health. Thank you.
Thank you, Dr. Sakulanda. I see many more hands, so maybe we'll take 5 and then we can come back for another 5. So my colleague from Ghana here, and then we can get a lady, and then we'll come back to the next way.
My name is Dr. Mark Nawani, the chairperson of the Health Committee of the Parliament of Ghana. Mine is a contribution much more than the question. African countries, we do not have a choice in terms of the trajectory that we are taking. From earlier presentations, we know that there's a reduction in donor funding by as much as 70%. And then the lessons that we learned from COVID has taught us that no, we either play the big game or we are left behind. When we needed vaccines, we could not get it. And so countries like Ghana, Senegal, South Africa, so many countries, about 4 of them, have already started taking steps to produce vaccines. And this direction we have taken, it is not that we like it or not, but we have to take it. And so in Ghana, we have the Vaccine Institute that is expected to partner the private sector. About $50 million has been set up this year for that. My other concern is the self-care. If you look at one aspect of it, and that has to do with healthy lifestyle, of course, exercises, jogging, etc. It is true that, yes, this aspect is good for us to follow. But now, if we look at social media and what usually they propose, and the self-medications that go on, I'm afraid, but we need to be cautious so far as this self-care program is concerned. I think the Ministry of Health and Parliament and other stakeholders have to take over and sanitize the environment, or else social media is going to dictate the pace, and I believe that some of them, the direction is not that good for us. Thank you.
Thank you so much, Doc. We have first the last question from our lady here, and then we'll come for the second question.
Thank you very much. My name is Dr. Amina Urai. I work with Pathfinder International as the Regional Director for West and Central Africa. I'm really pleased to be here, and my question really is to my former colleague, Professor Joachim Uso. So, Prof, you mentioned about self-reliance for health systems in Africa, and I wanted to just point out a few things. One is the government-to-government compact you mentioned. Is it possible for us to have maybe a one-pager for the members of parliament so that they will better understand what the issues are and what the agreements entail and what we think they should do? Because it's really important that you mentioned we need to have a united front, you know, for this particular compact so that all countries in Africa can have one voice and face, you know, development sector and face other countries, because now it's about the Africa First agenda. So that would be helpful as part of the Lusaka maybe declaration or call to action from this meeting, you know, just to provide some information. The second thing still is really put to Prof. also. So for me, I think research is very critical, especially homegrown research, because the issues of Africa and the diseases of Africa are unique to Africans most times. And you also mentioned, all the 3 speakers mentioned about the unique, you know, infrastructure and all within the region. What is the role of universities in health research, and how can members of parliament, you know, make sure that they provide enabling policies that would support even the private sector, in addition to the universities and academia, private sector also to have an enabling policy environment to invest in the health system. So these are my comments. Maybe what can we do as parliamentarians here and as we as supporters of government and institutions? Thank you.
Thank you so much, Dr. Abina, for that two very important interventions. We're now going to turn to our panelists to pick up questions. I'll allow you to pick questions of your choice. Point to my mic. Let's start with a lady. So let's say ladies first. Vivian, you can pick your choice, and then we come to Prof.
Thank you very much for the questions and the insight. So I'll start with the one from the Member of Parliament from Malawi on, do we think we're going to achieve UHC? I think that's, a civil society, something that we continue to monitor, but also that there's been progress. When you look at the African countries and the UHC tracker, you see that African countries actually have made progress in most of the indicators that we have under that. So we have indicators around changes in service coverage, provision of services like reproductive, maternal, newborn, and child. Some progress has been made. However, it's about the investments that are being made into these services. So you as members of parliament have a critical role to play to ensure that adequate resources are provided for the provision of services. The other aspect is financial hardship. As long as we still see people paying from their pockets to access services, we may not achieve UHC, because UHC is meant to ensure that no one bears a financial burden when accessing the services. So on that one, we still have some progress to be made. And do we think in 5 years it can be done? That's a very big question that we need to continue looking at and asking ourselves and advocating through domestic resource mobilization. The other question was on the role of members of parliament in local manufacturing. With the responsibility of members of parliament in terms of formation of legislation, I think your role will be very critical in ensuring that we've got the appropriate legislation to support local manufacturing in different countries. We know that for DDC is kind of supporting or coordinating that PUD mechanism for local manufacturing. So it's continued, it's the buying in of the government. Buying in might mean increased financing for such a fund. So as members of parliament, you need to ensure that we ring-fence resources to support local manufacturing. In addition to that, we need the adequate skills. So within that fund also, we should be able to see resources being allocated to ensure that we've got the right skills to be able to produce the medicines that are required in country. And this should make it cheaper for us to access these services and ultimately reduce the burdens, especially for those in rural areas. Thank you.
Yes.
Thank you. Yeah.
Just to remind that we are live on both Parliament TV and radio, in line with taking Parliament closer to the people. So we are.
Okay. Thank you very much. Will we achieve UHC by 2030? A very difficult question. For me, it is difficult because countries are at different levels. So some countries are making great progress, others are still need to do more. But also, there is an ecosystem beyond the country that needs to be fixed. This is what I meant by multilateralism being part of how we approach this issue. That ecosystem out there seems to be becoming more and more complex. And we are backtracking on a lot of gains that we have made in the recent past. WHO, for example, if you kill it, what does that mean for UHC and all the other players in global health? How will we do surveillance for pandemics and epidemics? How will we work together on climate and health? So there is an ecosystem out there that needs to be fixed as we also do what we have to do at country level. And so depending on how that pans out, and I think policy and parliamentarians and all people in leadership have a great role to turn around some of the things we are seeing. Depending on how that pans out, some people will succeed, others may not. And as I said, this divide and rule strategy, where 14 countries in Africa are signing America First strategy, others are refusing to sign, others are signing and their parliaments or judiciary rejecting, that needs to be fixed. What is our one strategy for Africa that will help us achieve UHC? I think that needs to be discussed and agreed on. The issue of inequity, our colleague from NEMA, Charles, and the fact that there are a lot of social determinants of health outside the Ministry of Health calls for closer collaboration, intersectoral collaboration within the country and outside. There has been a push for health in every ministry rather than Ministry of Health. A situation where the Ministry of Health becomes a coordinator of health interventions in every ministry. If you think of every ministry, whether it is agriculture or water or transport, deaths are happening because of issues in those ministries. So how can we coordinate and work together with Ministry of Health to make sure there is health in Ministry of Agriculture, that we are not using harmful chemicals, that we are not using foods or growing foods that will later lead to cancer, that transport is safe and so on. So greater partnership, thinking of health beyond Ministry of Health and having Ministry of Health as an overall coordinator for me is very important. On the issue of self-care, our colleague from Ghana, self-care is there. When people miss health in the mainstream health system, they resort to healthcare. They either use herbs or they use other things, or they go to pharmacies, or they simply stay at home, or they adopt unhealthy lifestyles and so on. There is need to regulate self-care and institutionalize it. In that way, then it becomes more beneficial, and especially in a continent where access to formal services seems to be a problem and it will take time to get there. So we can get more by regulating it, by making it safe for our people, by incapacitating them to do it better. And I think WHO has come up with a clear way of how to do that. There are technical agencies out there that are ready to work with us to make sure it is okay. Finally, Dr. Amina, thank you. The issue of, I think we need a policy brief, hopefully from this meeting, on how we deal with this multilateral quagmire that we are in right now. I know US is very loud, but this is something that is happening across the world, even Europe and other places. They're diverting and rethinking the way they support global health. And so Africa needs a stand. I think our undoing is we are seeing ourselves as victims. We are recipients of decisions that we are not part of. Africa needs to have a stand. We need a policy brief that can guide our decisions on these matters of global health funding and collaboration and so on. And we need to be careful on this divide and rule strategy that is becoming more and more apparent. On the issue of how universities can contribute, I know we have a problem, linking academia and industry, operationalizing or translating the evidence we generate from universities into real actions that are beneficial. So there is a lot of work there. It's a whole discussion we can have around that, but definitely there is a problem where you have many professors like me not giving solutions to the problems of the day. We need to discuss that.
Thank you so much, Professor Osu. We will now hear from Dr. El Hassan, and I think there was also the question which was to do with the, what do you mean on the sexual reproductive health and rights?
Yes.
So I'm aware about the Africa Medicines Authority, AMA, on the issue of drugs production, which my colleague from Ghana talked about. So let's incorporate that in the discussion. Thank you.
Yeah, thank you. That's a very good question. On what government should do regarding SRHR, or what I mean by what should government focus on? I think 3 key issues. You know, we've made a lot of progress, as you mentioned, on SRHR. And a lot of the progress emerged mainly from funding that we receive for our SRHR program. So in most of our countries, on commodity security, upwards 90% of funds for contraceptive commodities were procured and supported by donors, mainly through UNFPA and other UN agencies. So if donor funding is drying up, it means commodity security is at risk. So what government should do with SRHR commodities is to make sure that the drying up or the declining of international donor support doesn't result in us running out of contraceptive commodities in facilities when people need them. So that is one area. Number 2, you also realize that the populations that are underserved in terms of access to SRHR services are also those that are severely impacted by climate change impacts. So on the one hand, they are underserved when you come to SRHR services. On the other hand, they are experiencing adverse impacts of climate change. So in the current issue, we need to also amplify and prioritize those underserved populations so that we don't say that we are making efforts and then we stop there. So we really need to go the next mile. And then the third one has to do with an integrated implementation framework. Right now, we are dealing with reproductive health directorates are working under the Ministry of Health as standalones. So if you don't have money and you have all these departments working in silos, it means you are going to be spending resources doing the same things across different departments. So we are proposing that governments adopt an integrated implementation framework that allow all actors within that framework to cooperate. For instance, you have the health workers, and Malawi has a very good model where you have the community health workers that Professor also talked about. These community health workers were trained to provide general health assistance at the community level. Now, the family planning program in Malawi actually gave additional training to these people to be able to reach people in their homes. So those cadre of workers, we call them the health surveillance assistants in Malawi, have become a very important component of the delivery of SRHR services. So it means that we have an opportunity to even extend or integrate with other institutions or other personnel within the health structure. So that is that one. On behavioral change, I think that we need to shift our mind because the game as we have known it since 1994 ICPD has changed. We can't keep the same framework because funding has changed, priorities have changed, those that to set the agenda have changed. And because the agenda setters are no more there, we don't sit back and all the progress we've made over the last 30 years will be reversed because we've not paid attention or we've not put enough funding into contraceptives. I want to address the last question on the role of African universities and research centers. I work for a research organization in Africa And one of the things we have been advocating for is how do we get African researchers to actually generate research that is relevant to address our problems. So there is issue of even the capacity of our universities to be able to, because you can't generate good research without funding. Most of our universities' research is being funded through international research programs where our people are just co-PIs or data collectors. How do we get African researchers to generate ideas or evidence and attract funding? It also means that government have to put their money where their mouth is. If you don't have a research fund, how do you expect researchers to generate that knowledge? That is one step. The second has to do with translating that knowledge, which is where we as AFIDEP and similar research organizations fit in. Because sometimes the research is generated, the data is produced, nobody does further analysis or even engage policymakers, members of parliament with this type of research. Apart from generating that evidence, you need to translate it and engage the policymakers to understand what the implications of that evidence mean in terms of what does it mean for resource allocation? What does it mean for coordination? What does it mean for our targets? So there also has to be the extra mile of not just generating, but translating, engaging members, and then implementing. Because we are good at ending at the policy level, we need to implement, monitor the progress of those implementations, learn the lessons, and correct course for progress. So there's a role of the university, the researcher, the research institution, the researchers themselves, but think tanks like us play a significant role. And policymakers and MPs will be important to actually advocate for funding for research in Africa. Thank you.
Yeah, thank you so much for this round of questions. I think we will now come to the second round. Unfortunately, we have to eat a bit of your lunch time, so take 10 minutes from your lunch. Let's start from this side. We now go this way. I start from my friends from Uganda, there. And my friends here from, is it Mali? What's the country? Yes. Let's start from this. Chad, yes, Chad. In N'Djamena. Excellent. Yeah, we can start from the Chad team, Uganda.
Bien, merci. Bien, merci. Je m'appelle Abakar Mala Moursha, je suis sénateur, je viens du Tchad. Je voudrais d'abord remercier les intervenants pour la qualité de leur intervention et me poser une question. D'après ce qu'on vient d'entendre et d'écouter, l'Afrique est assaillie de toutes parts. Et le dernier attaquant semble être le changement climatique.
I hope we are all picking him. Because maybe you may repeat, because I have just gotten into your channel.
Qu'est-ce qu'elle dit? Je peux continuer?
Okay, let's continue now.
Bon. Le dernier assaillant semble être le changement climatique qui a des effets néfastes sur le système de notre santé africain. Et il se trouve malheureusement que l'Afrique n'est pas seulement confrontée au problème de santé. Il y a tant d'autres priorités que l'Afrique ne saurait prioriser ses priorités. Parce que les priorités n'attendent pas. Par exemple, l'agriculture, l'éducation, le problème des routes, sont autant de priorités qui ne peuvent pas attendre, comme la santé. Et face à cette situation, l'Afrique a cru devoir se tourner vers une politique d'endettement pour essayer de s'en sortir. Et cette politique d'endettement induit également des conséquences sur ses priorités, parce qu'il faut payer et assurer le service de la dette. en assurant le service de la dette, c'est autant d'argent de sortie qui ne sont pas affectés pour ces priorités. Ah, donc, le problème demeure pour l'Afrique. Et face à cette situation, le parlementaire que nous sommes, nous avons toujours joué notre rôle, celui d'être vigilant sur la soutenabilité de la dette, le profil de la dette, veiller à ce que la dette soit au maximum concessionnelle pour ne pas contracter des dettes commerciales qui sont plus exigeantes, veiller à ce que les secteurs sociaux, notamment la santé, aient une allocation budgétaire conséquente, parce qu'il faut financer les infrastructures sanitaires, recruter les personnels de santé, améliorer leur qualité, acheter des médicaments. Donc, autant de facteurs, autant de défis qui sont contenus dans la politique sanitaire qu'il faut que le parlementaire doit être vigilant. Je crois que ce rôle, peu ou prou, on le joue. J'aimerais tourner cela vers la dame, la présentatrice, pour demander le parlementaire, que peut-il faire de plus que ça? Est-ce qu'il y a d'autres voies, il y a d'autres moyens que le parlementaire pourrait être utile dans l'instauration d'un système de santé résilient, équitable et durable? Merci.
Thank you so much. I think we give the first French speaker enough time. For the rest of you, I'll ask you to just be very short on your questions so that we can go for our lunch. So this session is standing between your lunch and this session. So I see several hands. I had given chance to the Uganda behind. Okay, Chad, maybe a very short question. You're from Chad as well, yeah? One holding the mic. Just a very short question, please. A very short question, go ahead.
Merci. Je réponds au nom de Mbaïgol Sébastien, sénateur venu du Tchad. Intervention des uns et des autres. Il apparaît clairement que le système de santé mis en place, et particulièrement dans l'Afrique subsaharienne, est confronté à plusieurs défis. Cette confrontation fait que ces systèmes ne répondent pas aux aspirations de la population. À cela, la CSU apparaît comme un levier qui permettra donc à corriger ces insuffisances, sinon améliorer la couverture sanitaire au profit des populations. Alors, la question que je voudrais poser donc au deuxième intervenant, c'est de savoir comment rendre la couverture sanitaire universelle viable dans un contexte de choc climatique répété et également de dépendance au financement extérieur. Merci.
Thank you. Uganda next.
Thank you. My name is Pio Samuel Achuri, Deputy Chair, Health Committee, Parliament of Uganda. My question is to the first presenter, Professor. Give the investment case of for every $1 in health, we get $19 in economic returns. However, the challenge has been really on having translation of this information. The $1 that we're investing in health, percentage is going into supplies, percent health, what percentage is going into reproductive health. I think there's really need for research to unpack this information. And then when you go ahead and talk about a $19 return,
the Ministry of Finance will ask you, where is that return? Is it coming from agriculture? Is it coming from trade? Is it coming from another sector itself? So I think it's very key that we begin to unpack or present data which we can be able to translate. At times the challenge is a translation rather than the information itself. The second is to the presenter about climate change and health. And when you look at it, you begin to realize that we need to have health in education, health in agriculture, health in gender. But you know, for that to happen, you talked about integrated implementation. We need to start having integrated planning, integrated budgeting. Unfortunately, we don't seem to have a model. Even here as we sit, we are sitting as health, but yet we're discussing the need to have it in gender, in agriculture. So are there some successful models that we could perhaps draw from, that we can go back home with to see how to? Thank you.
Thank you. We have Hans here.
Thank you very much, Mr. Chair. Mine is, I just wanted to share our Ugandan experience when it comes to sexual and reproductive health. I noticed that sometimes we Africans kill ourselves unknowingly. We like to operate in silos. In Uganda, to tackle some of the challenges of maternal mortality and neonatal mortality, we have embraced what we call local maternity networks. And that is a network of health workers, policymakers, even the politicians within a particular geographical location. And now with the advent of WhatsApp, you see real-time challenges. If a hospital doesn't have blood, if a health center doesn't have gloves, you know, everybody is like, which of my neighbors has blood group A, who has blood group O, and we're all on the move. If an ambulance doesn't have fuel, an ambulance from another district will come to the rescue. And we as the policymakers, like when I was the chairperson of the Health Committee of Health, I was on those platforms, and you're being bashed because we are the ones who appropriate the budget. So there is real-time action, and I can trust you that we have saved many lives of women who would have, in my opinion, died if we do not have such a level of coordination. And then finally, on the issue of the community health strategy, we have one in Uganda, and where we have our community health workers and VHTs. If I borrowed a leaf from the way we saw the Ebola pandemic ravage West Africa, especially Sierra Leone and Liberia. We've had Ebola in Uganda, but we have not hit the mortality levels that we have seen in Liberia and Sierra Leone. And it is because of a functional community system, whereby even if there is a death, the police will pick it up. Security is not only about, physical death, but if there is an unsuspected death, then they'll translate that up to the systems, and government intervenes in time. Thank you.
Thank you. There was a hand here. Yes, the gentleman with the... Then we'll go to the back. I see at the back we have two hands before we come this side. We'll come to you.
Okay. Merci beaucoup. Moi, je vais m'exprimer en français. Honorable Abouakar Sidik Fomba, je suis le président de la commission santé, du développement social et de la solidarité du Conseil national de transition du Mali. Je félicite d'abord les présentateurs pour la présentation des qualités, des explications claires et nettes. Cependant, je m'en vais directement à un certain nombre de questions. Est-ce qu'il n'est pas temps de revoir la déclaration d'Abuja? À mon avis, la santé doit plutôt être axée, le financement de la santé doit être plutôt axé sur les résultats que de se focaliser seulement sur la déclaration d'Abuja, qui, à mon avis, doit même être évaluée et comparée à l'évolution actuelle de la situation africaine. La deuxième des choses, nous parlons, nous décrions ici la dépendance au financement extérieur. Au même moment, l'Union africaine même dépend du financement extérieur. Pensez-vous qu'il est cohérent que l'Afrique continue ou l'Union africaine continue d'être prise en charge par le monde extérieur et que nous passons ou nous parlons de l'autofinancement? Est-ce possible? N'est-il pas d'abord mieux de corriger cette dynamique souverainiste, de faire en sorte que les Africains puissent financer l'Union africaine et faire face à leur propre politique? La troisième question, c'est par rapport à la recherche et à l'utilisation des données probantes. Je pense que ça a été évoqué par le Tchadien. Aujourd'hui, tous les textes que nous utilisons sont caducs. Et nous travaillons sur la base des recherches d'autrui. N'est-il pas nécessaire aujourd'hui, puisque nous avons des chercheurs, nous avons toutes les personnes de qualité, d'utiliser d'abord, de financer nos propres recherches et d'utiliser les résultats de nos recherches dans nos décisions politiques? Je crois que ça aussi, ça peut être le rôle du Parlement, d'utiliser les données probantes dans les décisions politiques. D'autres questions, avant-dernière question, le professeur a parlé du multilatéralisme comme élément important dans la diplomatie parlementaire pour en faire en sorte que nous puissions parler de la santé sécuritaire et de l'économie. Peut-il expliquer concrètement en quoi cela peut-il être important, cela peut être avantageux dans un contexte de monde géopolitique où nous savons déjà, nous tirons chacun des leçons de notre côté. Et voilà, la dernière question, c'est par rapport à... Non, je vais terminer. La dernière question, c'est à comment pouvons-nous faire de telle sorte que les pays africains puissent se donner la main pour que nous puissions faire face aux problèmes africains avec une dynamique cohérente. Merci.
Thank you so much. Let's go to the back. Also, I see two hands there before we come to the left. At the back.
Thank you so much. So my question is quick and it relates to a point that Dr. Awasan mentioned when you discussed the issue of clinical trials and clinical research and how it can lead to evidence generation. And I just wanted to ask you, what do you think parliamentarians should do to facilitate that transition so that clinical research is no longer treated as a peripheral aspect of healthcare, but rather as a key component of it? Because globally, for example, in Europe, there is accelerating clinical trials in Europe, which is a program aimed at making sure that clinical trials are at the center of healthcare delivery. And this translates to technology transfer, which benefits when it comes to issues such as resilience, responsiveness to pandemics and things like that. What do you think parliamentarians in Africa should do to facilitate that transition from periphery to the core when it comes to clinical research? Thank you.
Please, let's take the mic to the back. The people with hands at the back.
Thanks so much. My name is Ibrahim Abdallah. I work for Clinton Health Access Initiative here in Zambia. It's a privilege to speak before people who ordinarily would require a vote to get to talk to. My question is around self-care and then local manufacturing, and specifically with regards to assistive technology and assistive products. Assistive technology, assistive products have been very minimally funded, and then their kind of procurement mechanisms are quite disjointed. So as a region, and then as an August House of parliamentarians who has that kind of power to be able to kind of streamline frameworks to be able to ease up that space, I wish to draw your attention to that big gap in terms of access to assistive products in Africa. Largely is donor dependent, and some of them come in ways that you have to kind of modify, and they don't eventually serve the purposes they are meant for. So basically things like wheelchairs, spectacles, prosthetic devices, and so on and so forth have become very, very difficult to come by. And urge you as a very important leadership in our respective countries to consider that in your consideration when you are thinking of universal health coverage. Thank you.
Thank you. Behind.
Thank you very much, Chairperson. My name is Lioka Lioka. I'm from an institution called Medicines Research and Access Platform. We are into policy and research. My question is around health sovereignty as an emerging concept, as discussed by Professor Osu. When we talk about clinical trials and research, and when we look at the tendency of our budget system in the African region, it reflects a more consumptive approach than an investment into research and development, which, if we talk about the aspect of health, no longer a social service, but a strategic economic sector. I have a challenge, Chairperson, to our able members of parliament in the African region. How can we begin to translate the aspect of health being an investment, our case, in the area where we have our national budget, for health being largely consumptive than reflecting any investment into research and development. Thank you very much.
Thank you. We're going to take these. I think there are almost 60 interventions. Then we'll take the last ones. So even you, the presenters, please could you be very short on your answers in the interest of time so that we can break off for our lunch. So you have a choice. Let's start from Dr. El Hassan. You can use mine.
Thank you. So I'm going to address the question from the honorable member from Chad. He asked a very important question about prioritization, because we have competing priorities. Health is emergency, education is emergency, unemployment is emergency. So there are competing issues. So the question is, how can we prioritize health in this competition? Two things. The first is integration. I think we have been working in a siloed approach, so sectors are competing with each other for resources. When they can you can have integration so that if the Ministry of Health is implementing a program that needs the Ministry of Education, you don't have to then say that, okay, they should have joint planning, so that you are not sending resources to education. Education is duplicating the same thing that health is doing. Environment is doing the same thing. So I think for effectiveness, we need to emphasize integration to deal with the issue of prioritization. If we are sitting together in the room, we can actually cut budgets to see that, okay, let this ministry take care of this, because it has the advantage, competitive advantage to do that, so that we are not expending resources doing the same thing in different sectors. That's one. The second is accountability. When resources are not adequate, and the minimum we have, or the few resources that we allocate, end up going into expenditures that you can't explain, I think we need to tighten our accountability mechanisms. And Parliament sits at the center of that. So as a member of Parliament, whilst we are advocating for integration, there needs to be tightening of accountability measures so that every money that is allocated, there is a value for money. First of all, before it's sent, there's a value for money audit to see that, okay, this makes sense. When the program is being implemented, are we following up to see whether they're actually getting the benefits that they were intended to have? Secondly, it's related to the second question. I think is the honorable member from Uganda who says, as we sit here, we don't have an operational framework. You are right, but we can learn from some of those we already have. If you look over since 2017, if you go back to the African Union has tried to actually look at the demographic dividend. This is a very comprehensive framework that emphasizes integration. You can keep including other things. We at AFIDEB have tried to actually take this framework forward, worked with countries like Uganda, Zambia, and so many other countries to see. And when you do the modeling, you realize that countries that actually integrate, the size of the dividend they earn and the period they earn it is higher and faster than those that continue on this siloed approach. So that is a low-hanging fruit that we can revisit, because a lot of the time it ends at the discussion and the framework. It doesn't go beyond that to the implementation and even the mechanism for monitoring. Our auditors, they are not sitting in the room when the plans are being made. They only come back after the implementation to start asking questions. All of us should be in the same room: integrated planning, integrated resource allocation, implementation, monitoring, and evaluation. Then we can get the benefits. The WHO has proposed a framework, an operational framework, which was in 2015 and then updated 2023. It has like 10 pillars. We can also integrate that into the DD framework, but it needs to be something that works, not because country by country, how it's implemented might differ. But at least we have guiding principles around that. Lastly, the question around science, evidence, and the role of MPs. Thank you. I think it's a very good, and the honorable member, Honorable Nawani from Ghana, talked about the Vaccine Institute. That's a very good example. You see, that is research, because whatever vaccine you develop and you try it, then there will be evidence about its impact and what it has done. Members of Parliament following this Vaccine Institute right from its inception can follow to say, okay, now how much do we need to give to this Vaccine Institute to be sustainable? How can we develop the capacity of researchers, give scholarships to African researchers, young researchers, to be able to train, so that as we are empowering or strengthening the capacity of such institutions, people are learning, so that by the time the next senior scientists are gone, you have a pipeline of young people who are ready to replace them, so that you don't invest and don't gain the returns from it. Parliament is also, apart from the resource allocation, I always say our members of Parliament are probably the centers of integration. You go to Parliament and a lot of people are in queue waiting for medical bills, waiting for funeral, caskets for funerals. I'm sure that members of Parliament themselves are at the center of this discussion. So how can they become a voice to say that, look, we are struggling as members of Parliament to provide ambulances, to pay for medical bills. How do we ensure that our governments are putting resources so that we don't take up that role? So members of Parliament will be important, both in amplifying the voice, resource allocation, and ensuring that young people are given opportunities through government scholarships, bursaries, so that they can study and improve their skills to replace the next the generation before it. Thank you.
Okay. Yeah. Very quickly, I think there was the issue of how do we prioritize, because there are many priorities. I think if I become a politician, I don't know whether I will, because it's a very difficult job. I would listen to what people want. And from what I've seen in the evidence, if you ask people what is the most pressing issue, right now they are saying in Africa, we need jobs. Secondly, we need healthcare. So we can use what the people are saying, because we are representing the people, as a way of getting the priorities. There was the issue of how we communicate some of these statistics, like $1 yields 19. I think that's something we need to discuss. Again, we could make it part of the policy brief from here to be able to communicate it to decision makers and to parliamentarians to use it to convince our colleagues. There was the issue of use of evidence. I think this is very important, being evidence-based, but also indigenous knowledge. There are things which are unique to Africa. And so as we need to generate our own local evidence, and also really don't neglect our local knowledge. There is a lot that we can benefit by learning things the way we have been doing them, and if it works for Africa, ensuring that we do them. And I think finally there was the issue of the geopolitical issues. How do we deal with them? Again, I think NEAPACOH may want to have some policy brief from here, as we've said, that will guide the discussions going forward.
All right, let's hear from Vivian. In the last round, I'll only ask 3 questions because there was some people there in the middle, yeah, who had hands up. But you only have half a second to ask your question each. Yes,
Thank you,
Vivian.
Honorable Member. So I'll start with a question from the Member of Parliament from Chad, where he was asking what else can civil society do to support parliamentarians. I think our role as civil society is really to build the evidence, and the fellow speakers have spoken to that. We continue to engage the communities, understand the issues, and also we understand that you are politicians and we have the technical know-how. So we come to you with the evidence, we come to you to build the capacity to ensure that you understand the issues. In Zambia, we have there's the health committee, but we also have the caucuses. The caucuses are kind of focusing on specific areas, disease areas, so on sexual reproductive health, immunization. And we continue to engage the parliamentarians on those specialized issues to ensure that they have the knowledge to support their policy decisions in Parliament. And then the issue of prioritization, Dr. Su has spoken to it, but also want to talk about prioritizing health promotion, which is health care to some extent. Our group CEO talks about how in health, we only go to facilities when we're sick, comparing ourselves to cars. We don't only take to the garage when they are dead, but we take them for servicing. So if we invest in health promotion, we ensure that we're looking at the productivity of the population, and ultimately this speaks to health being an investment rather than an expenditure. How do we ensure that we have healthy populations to support the productivity of the countries? With regards to 15% Abuja Declaration, for me, I would say we need to focus more on closing the funding gap. So whether it's 15%, whether it's 10%, we know that some countries like Botswana are investing more than 50% of their domestic funding resources into health. So key to note is how do we close the funding gap to ensure that we are providing equitable services to our populations. Thank you.
Thank you. The gentleman there in a black suit. You had a question? Just next to where the chair is standing. Yes, you can stand up. You can just shout it if the mic is very far. Just stand up and shout your question. We have given you the chance. Stand up. Just stand up and shout your question. Yes, yourself.
Oui, je voudrais prendre à mon compte tous les remerciements que les uns et les autres ont adressés aux différents panélistes. Et ma question va plutôt au Dr. Joachim Ossou. Alors, dans sa présentation, il avait dit qu'il y a plusieurs priorités, mais 2 opportunités qui sont nos populations expriment. La première, c'est le soin personnel, c'est-à-dire prévenir la maladie, ou les soins personnels des personnes qui sont nécessiteuses. Mais la deuxième, ce qui m'intéresse, la santé digitale ou numérique. Quand on sait que, on connaît les progrès et l'efficacité de la santé digitale, mais quand on sait que dans certains de nos pays, la couverture réseau est un problème, que ce soit satellitaire ou GSM. Alors, comment peut-on promouvoir la santé digitale ou numérique? C'est ma première question. Je pense que, bon. Et la deuxième, qui rejoint un peu ce que les uns et les autres ont dit, mais moi, ma préoccupation, elle est concernant les fonds. Les fonds qui sont mis à la disposition de nos systèmes de santé. La plupart de ces fonds sont des fonds des Nations Unies, hein, USAID, etc., ce que vous savez. Et nous avons vu dernièrement que le président des États-Unis, le président Trump, a supprimé tous ces fonds en faveur de l'Afrique, et ce qui a handicapé beaucoup de nos organisations, de nos pays même. Alors, depuis 60 ans, l'Afrique est indépendante, depuis 60 ans. Et nous avons des organisations...
You can summarize your question. I had said just a second, please.
Oui, alors, je vais directement à la question. Nous avons eu des cas, pourquoi aujourd'hui ne pas s'inspirer, hein, de ces fonds qui sont mis et créer des fonds qui nous sont propres pour venir solutionner nos problèmes plutôt que d'attendre des fonds à l'extérieur. Et quand ils sont coupés, nous sommes complètement handicapés. Merci.
Thank you so much. I think politicians, they always talk, so can we reduce on the talking and just ask the question? So the two ladies there will be the last ones, unfortunately, because we have run out of time.
Seems I don't have to get up, which is great, or I must stand, I am not sure. Good afternoon, colleagues. Thank you so much for the presentations. I will prioritize the questions in terms of how do we operationalize some of the recommendations. Our learned colleague, the researcher, you spoke to one strategy for Africa, I believe. And my question is, this is a resolution that comes out quite often in these rooms. If you may provide maybe 2 action points that we can take back to constituencies, wherein we may say we can do 1, 2, 3 activities so that Africa is singing from the same hymn book. The second is around the regional economic communities and their role here, because they do have a space for parliamentarians. And I think as the engagement began, it was said that parliamentarians are the brains behind the discussions happening in many of these ministries. So how do we bring them on the ground? Because all of these conversations are happening in individual spaces. We attended one just now in February, where in discussions like regional manufacturing, capacity around research were on the agenda. Here we are again, it's about to be March, we're having the same discussion. So my question will be, as we are pushing for the strengthened advancement, and the word there is repositioning, which to me says innovating around what we have already done. What practical steps can we take to bring Rex into the room, but also to get Africa to sing from that one hymn book? Thank you.
Thank you. The last question for this session.
Good afternoon. My name is Mambo Mwemba from AIDS Healthcare Foundation. May I sit?
Yes, please.
And my question goes to the House. We heard from Dr. El Hassan that Kenya is so far the only country that has developed a national strategy that looks at health through the lenses of climate change. I want to know if this House has asked Kenya to lead on this issue alongside African Union, so that the rest of us as African countries are not reinventing the wheel, considering the limited resources and the time left to 2030. Thank you.
Thank you so much. Panelists, can we quickly and a minute each respond to those 3 questions, 3 interventions?
Yes, so I would respond to the last question, which has to do with Kenya. I think, interestingly, the Kenya strategy came before the Africa CDC strategy. So what we can do, maybe NEAPACOH can make a decision in terms of how can we learn from these 2 strategies, because they are quite new. If you look at the regional strategy, it has areas it considers priorities. They are not necessarily aligned with the Kenya strategies, but there are gaps, so that other countries that are here and wanting to go the same route don't have to reinvent the wheel, but also to include the areas that have been omitted at the regional level, particularly SRHR and the Kenya strategy. That's what I'll propose. Thank you.
Yeah. On the issue of how we move the things we've agreed on forward, I think NEAPACOH normally comes up with a resolution and country work plans every year. So I hope that some of the good discussions we are having will go into those work plans, and that moving forward, maybe we will be reevaluating whether we have done what we agree on in NEAPACOH meetings. So looking forward to the work plan, and we can contribute as needed. And finally, on digital health, where there is no internet access, I think partnerships is what works best. Private sector, for example, partnering with public sector, and also the civil society NGOs have been able to achieve a lot in such places. So I would go for partnerships.
Madam, okay, she has no intervention. Thank you so much, our audience of parliamentarians and the cooperating partners, as well as our panelists, keynote speaker, Professor, for your wonderful delivery, and my two colleagues. I think it's clear that from the objectives of our session, it was about knowledge sharing, sharing good practices, and fostering continental learnings and opportunities, optimizing technical expertise, which we have gotten from the academic, on strengthening our health systems, as well as implications for climate change in exacerbating the fragility of health systems. I think we have come to understand that integration is one of those keywords that has come out very strongly, that we can integrate health in all areas of development for us to be able to get value for money by doing more with the little resources that we may have, especially now with the dwindling donor funding. And so accountability becomes very, very important. And as parliamentarians, it's our job. That's why we even have the budget committees as part of this NEAPACOH, so that we can emphasize on accountability of these resources. It's our job as parliamentarians to ensure that these resources are fully accountable for. So the little resources we have in our countries which we are generating, we need to ensure that they have bigger impact. And so we look forward to the policy brief to incorporate all this information that has come out today, including the issues of digital health and partnerships, which can also impact on our populations. We definitely have the mandate and responsibility as parliamentarians to do better for our populations, our electors, to give them the best and quality health care. And by doing that, we have to ensure that we hold the executive accountable, and we have to give the executive the correct policy direction as we approve the health programs and the budgets that we approve for our populations. That way, we may satisfy our populations, and we can change that index and trajectory which has been shown. So signing off is Honorable Dr. Joseph S. Musanje, Chairperson, Health Committee of Zambia, who will now be free to take our lunch, even as I invite the panel for our final picture. Thank you so much for this session. Thank you. Give them another hand. They spent a lot of time researching. Yeah, thank you so much. Good. Secretariat, over to you. Thank you.
Thank you for still being with us on Parliament Television. The second session, which was more of a panel discussion, has just come to an end. Pauline, we just ran through what the panel discussion was discussing.
Yes, Taza, we had opening earlier in the morning of the 17th meeting on the network of African parliamentary committees on health, right here at Mulungushi International Conference Center. And the Honorable Madam Speaker did open the this meeting. And after that, we have had a number of presentations by various presenters. And this morning's session was on advancing resilient and self-reliant health systems for attainment of universal health care in the sub-Sahara Africa region. And the moderator for this morning was Honorable Dr. Joseph Munsanje, Member of Parliament from Mbabala, and he's also chairperson of the Parliamentary Committee on Health. So under these subcommittees, we had, rather under this panel, we had a keynote speech that was delivered by Professor Osu. He is a professor at the Ambref University, and he did give a keynote speech on whether African countries are on the right path, trajectory in health or in with regards to the advancing resilience and self-reliant health systems for attaining of the universal health coverage. So, Taza, we look at other presentations that have been made.
Yes, indeed, Pauline. We had presentation by Dr. Nuruddin Al-Hassan and also Miss Vivian Sikanga. We will be able to give the details of these presentations at a later stage, but just now we are going to break as this has come to an end. But remember, we will be broadcasting live the parliamentary proceedings, which we do expect to commence at about 14:30 hours. Keep watching Parliament Television, the only station that brings Parliament closer to you.
Good morning, Mother Nature. angel painted the sky for us this dawning. She took